press start, I'll give you a thumbs up when we're ready on.
Yeah. Good afternoon and welcome to this week's Grand Round, and it gives me great pleasure to welcome Robin Harrison, who is the local BMA representative to the Trust, to talk about the BMA, but also specifically about sleep and wellbeing. I think remembering to look after ourselves so that we can look after patients is extremely important. And I have to say, rather than thinking of it just in terms of pastoral terms, I do now think of it very much in terms of a patient safety issue. And so it gives me great pleasure to say thank you to Robin for coming and talking to us today.
And I'm the BMA Industrial Relations Officer, covering Southport and Ormskirk amongst a number of other trusts. I'm here to talk largely about fatigue and sleep, and the impact on working patterns, the impact of doctors' working patterns on fatigue and sleep. I would also, certainly at the end, be more than happy to take questions on any BMA issues at the moment. I think particularly sort of national issues around Clinical Excellence Awards for consultants or new SAS contract, which I've already done a couple of presentations at the Trust on. But if anyone's got any general BMA queries, then please feel free to ask. So on fatigue and sleep, why are doctors at risk of fatigue and sleep deprivation? Well, in general, adults need 7 or 8 hours good quality sleep a night. And that, of course, is not always straightforward and easy when doctors are working. You are at risk because you work long hours, whether that's, well, a combination quite often of long shifts and or long weeks. So, you know, the 10-hour plus shift, the 60-hour plus week. Clearly not every week, but or shouldn't be every week. But there is that. Both those provide certain risks around fatigue, as does a lack of rest. Both within shifts, so that sort of constant high intensity working throughout a shift without a break, but also, you know, that rest period as you finish one shift and having sufficient rest before starting another. Obviously, it is intense, it's complex work that takes a lot of concentration, a lot of time, and I think the complexity of work again contributes to fatigue and sleep. Sleep disturbance, obviously when you're on call, if you're on call at home, you get phone calls that disturb your sleep, or even potentially, of course, the anticipation of phone calls that can disturb your sleep. And to some extent, that's even true when you're working resident on call, the difficulty and the unpredictability of those breaks. Shift working, you know, there are, again, fatigue associated with late nights, with early mornings, and particularly with abrupt changes to your working pattern. And you know, I was reading up on this and preparing this, and it struck me that the impact of age is that there's a lot of research that actually shows that it's less easy to adapt to unpredictable sleep patterns the older you become. And as someone of a certain age, it says it's sort of in your 40 to 50 is the time when that starts to hit. So I'm well past the point where I'm less able to cope with those disruptions to sleep patterns. So what impact does fatigue and sleep have on doctors? It affects your cognitive psychomotor skills, memory, attention, and your performance in the short term, whether that's relating to your clinical work or to other activities you're perhaps doing out of work, whether that's things in the home, driving, that has a considerable impact on that. And then there is research linking disrupted sleep patterns to a whole range of rather scary sounding medical consequences. And I'm not going to go through and not intending to frighten people, but clearly a better sleep pattern is better for your overall health. What can we do about this? I mean, on the whole, from the longer term, there is need for a more comprehensive approach for the medical profession. In the short term, we're looking from the BMA point of view by doing events like this to raise awareness of risks and what trying to get employers to provide support for those who have disrupted sleep patterns, but also trying to anticipate and manage the risks, changing working patterns where it's possible, making sure that contractual and health and safety requirements are met. Longer term, I think there is probably a sort of national approach required to reducing the risks, developing models of service provision which actually protect doctors from some of the risks associated with sleep deprivation. I mean, clearly we can't have a model where patients are only ill at times that are convenient for doctors, but I think there are ways of looking at service provision that can help. So what can you do at the moment yourselves? I think it's important that you take steps to understand what factors optimize your ability to manage, anticipate fatigue. You know, how can you improve your sleep routine? How do you prepare for shift work and being on call? And there's some quite detailed advice on the BMA website about things such as preparing for the night shift and dealing with the transition between working days and working nights. I'm not going to go through it in huge detail today, but that's something that's available. You know, it's guidance that clearly you've all worked night shifts, whether they're resident or non-resident, and you will have your own way of dealing with it. But there's some useful advice there on the BMA website. I'll also talk a little bit about decision making a little bit later on. If necessary, you should, and you're struggling with sleep patterns and it's affecting you physically or mentally, then support is available obviously from your own GPs, but also we would want trusts to make that something, through their occupational health provision, those sort of services available to you. I think there's a responsibility that you're setting out, you're meeting the GMC standards of essentially not, ensuring that you're alert and not so tired that you're unable to treat patients safely. And you of course have a professional obligation to not work when you're overly tired. And we need to have I suppose develop a culture where you're in a position that you can feel you can tell your employer when you feel unfit to work or continue to work because of fatigue. Very clearly the case is if you are fatigued, you shouldn't be working, and from a contractual point of view that would be what you might call compensatory rest. It would be paid. It's not sick leave. It's simply a fact occasionally of being a doctor. In terms of decision making, there are a few things that you can think about. Plan your day to break up times when you're making key decisions. Make sure that I appreciate it's far from easy to do that, but try to factor in some of the key decisions when you're at your most alert. For many people, that's first thing in the morning, not for everybody. Ensure you take breaks. I think that's really important. That's both within and within and between shifts. Certainly keeping hydrated and eating healthily. Just I suppose it's stating the obvious, but that does very much help you stay alert. Be prepared to question your own decision making. Take time to double check what you're recommending and what you're considering, perhaps consider putting the decision off, seek advice from a colleague if you feel that you are tired and you want some second set of eyes or some extra time to consider that decision, then where possible you should take that. Think about, this is, I suppose, very true. Think about your daily routine to minimize time to making unnecessary decisions. What are the important things? Try to manage your day. Try to devolve stuff where you can. Again, very, very important to actually sort of have some breaks from that high intensity critical decision making. The slides now really about what we're asking employers to do. We very much want job plans for senior doctors or work schedules for trainees to be designed and regularly reviewed, potentially including occupational health people, so they're not likely to cause, they're not designed essentially to cause fatigue. So we're looking to minimise shift patterns and rota changes that cause sleep disruption. There's research that suggests you should use forward rotating rotas, so you go from days to evenings to night work. Is the way to do that. Providing built-in rest breaks while on duty. Trainees in the junior doctor contract, that's clearly built in. That there are rest break provisions. I know very often it's difficult to enforce, but those contractual provisions are there, and we really should be making sure that rest is taken. And a reminder for trainees, both trainees and for those supervising trainees, that not having rest breaks is something that can be reported through exception reporting, and in fact, consistent missing of rest breaks is something where there is provision for the Guardian of Safe Working to actually fine the trust, to charge the trust amount of money, the fund then used for the benefit of the trainees. So please report it, because only through reporting things will that be known. There are, of course, no contractual provisions around rest in the consultant or in the SAS contract, but again, I think it's important that you take time away during your day where possible to have some sort of rest, even if it's just that sort of 15-20 minutes fresh air or whatever it is, sitting at your desk doing something different. Allow at least 11 hours recovery time between shifts. That is built into the working time regulations, and really we want to make sure that shift patterns are designed so that there is that sort of rest between shifts. I think it's very important that employers are monitoring the extent of interruptions while on call, and by that I don't just mean the number. I think it's the level, it's the numbers, it's the length of those interruptions, and I think it's important that the interruption is almost from when the phone goes when you're on call to when you're back asleep, not necessarily when you put the phone down. I think that's important. Time of day is important in terms of when are the calls coming, when are the calls most likely. You may find it easier to deal if you're on call overnight. It's probably inherently easier to deal with a call at 10 o'clock in the evening than it is at 4 o'clock in the morning, and I think it's important that those things are taken into account so that shift patterns can then be developed sort of in anticipation. If there are regular 4 o'clock disruptions in a particular thing, well, what are the implications for the following day? Can that be, rather than that being managed in an ad hoc way, can that be built into rota and shift patterns? And of course, we're also trying to avoid excessively long weekly and daily working hours where possible. We need to ensure that there is adherence to all contractual requirements for working hours. and safeguards and recovery. There are some very, as you're probably aware, in the junior doctor contract, some very clear rules around working patterns, working hours, numbers of long days, numbers of weekends, etc. There are also similar provisions in the just being introduced 2021 SAS contracts, where there is restrictions on the number of weekends to be worked, on the number of long days and night shifts that can be worked for those who do shift working. And we need to make sure that there is an adherence to that. There are BMA point of view, we attend junior doctor forums, we attend local negotiating committees where these issues can be brought up, and there are across the patch, including at Southport, 1 or 2 junior doctor rotas that are not compliant, particularly on the weekend working, and we're trying to work with the trust to get back to a provision where they do meet those contractual requirements. Need to ensure, as we've said before, access to occupational health. We need to provide facilities for rest during and after shifts. Again, I'll come on to that in a minute. We need to perhaps encourage team-based approaches to providing cover so that staff can take uninterrupted breaks. Now, I appreciate that can be very difficult, and we don't want a situation where doctors, for instance, are carrying, double bleep carrying. It's certainly been an issue in this trust a while ago. But can you leave the bleep with a colleague? Doesn't have to be another doctor necessarily in all instances, that allows you to have that uninterrupted break, particularly on night shifts where numbers are scarce. And ensure that induction programs or ground rounds or whatever have raised the issue of fatigue. And I have to sing the praises of this trust. I'm often invited to junior doctor inductions to talk about various things, but they're often quite keen that I talk about sleep and recovery and fatigue. Access to healthy food options, again, to contractual, well, I'm not sure about healthy, but certainly food options is a contractual provision in the junior doctor contract and in the new SAS contract for those working out of hours when the normal food outlets are probably not open. And I think perhaps most important in many ways is that last one of actually having a culture where staff are encouraged to raise concerns about their working patterns and about their fatigue. And I think it's really, really important that when staff do raise these concerns, that they are treated seriously, dealt with appropriately, and that they are seen to be so that it doesn't discourage colleagues from raising these issues in future. In terms of what the BMA is trying to do at a national level, say we've got this awareness campaign. We want trying to pressure government and health departments, NHS employers, etc., to highlight the risk of fatigue in the medical profession, and things I've talked about are the factors that are involved and how work is being done to improve how it's managed. Making sure that employers have got systems in place of the things we've just spoken about to limit the risks of fatigue. Making sure there's robust data on working patterns, and that isn't necessarily just data on what your rota says or what your job plan or your work schedule says, but actually what is it in reality. Now, I think it's important for you as individuals to junior doctors to exception report, where you where you work beyond what is in your work schedule. For more senior doctors, you may want to think about keeping a diary of that, of where your working patterns exceed what is in your job plan. I mean, I don't think anyone's suggesting that a clinic that runs half an hour over once in a while is a problem, but a clinic that always runs over, you know, that builds up. That working time significantly builds up into your working patterns and the potential for fatigue. Clearly, you need to identify workload pressures, and you know, there are, quite frankly, not enough doctors, but identifying where those workload and workforce pressures are that are creating the factors that can reduce in excessive working hours and risk of fatigue, and really trying to get employers to set out short and longer term measures to reduce that impact. Also, I think it's important that not just to review working patterns, but also trends in fatigue, how fatigue is affecting doctors and other clinical staff. And that can be a whole range of things, from looking at the impact on absence and sickness, or on the use of compensatory rest, potentially even people retiring or choosing to leave a particular organisation, you know, through exit interviews. Is excessive working, is fatigue one of the factors? From employers, clearly we need compliance with contracts. That includes accurate and realistic job planning and work scheduling. Again, making sure that things are done at induction and that there are appropriate facilities. I think in many ways the stuff on doctors, I think I've already covered many of that. Just talk very briefly about the BMA Fatigue and Facilities Charter. This is something that has been promoted by the BMA and adopted by virtually every trust in England in the last over the last 3 or 4 years, where recommendations are put in of best practice on issues around roster and rota design, induction, access to facilities, whether that's a common room or a mess, catering, travel, everything from provision of bike, you know, taxis home if you're too tired, to encouraging cycling, making sure there's rest facilities for doctors working on call and post on call, but also an attitude towards fixing problems as well. Now, there was money associated with the Facilities Charter. You may be aware that this trust had just over £60,000 to spend to implement that was granted to it. And I know after I finished the presentation, I think Anne Holden has got a little bit of an update on the latest on how that money is being spent. Just very quickly, I'm not going to go through this in detail. This is perhaps where we want to end up, with something that looks like the airline industry, where there are very strict rules around airline pilots and when they're able to work and how much they're able to work, their rest periods, a whole raft of aviation safety agency rules that are very restrictive, in a way that there are just simply not those restrictions for doctors. There are contractual provisions which you can seek to enforce, but there isn't the sort of legal framework that you have in an industry like the airline industry. And yet, you're in every bit a safety critical industry as they are, in my view. Just a reminder, really, when you're fatigued, you're more likely to make clinical errors, have needle stick injuries, or be involved in road traffic accidents. You know, there are, I'm aware of a couple of real horror stories of junior doctors having very serious car accidents on the way home from night shifts. It's thankfully, I'm not aware in my patch in Merseyside of there having been serious accidents, but I'm certainly aware of there having been accidents of doctors having car accidents on the way home. anecdotally been told by consultants that driving home from attending an on-call that they've fallen asleep at traffic lights and things like that. I have no, thankfully, as I say, no real horror stories. But your concentration suffers. The 17 or 18 hours without rest, your cognitive function is probably somewhere over the equivalent of the drink driving limit, and that's something I think you'd probably need to be aware before you get in your car at the end of a busy shift. Take advantage of taxis home or post on call sleep facilities, which I know Southport has. I think they are set out in certainly in the departmental handbooks that have been put together over the years, but certainly find out how you access those rooms in case you ever need them. I'll thank you for your involvement. I'll just end there with leave that for a second just to think. There is a number of reasons to join the BMA, and we currently have an offer on for people who are not BMA members joining of a free first month membership. Okay, I think I'll just ask Anne to update on the fatigue and facilities money, and then I'm happy to take any questions either about fatigue or about more general BMA issues.
Okay, so as I was outlining to Robin at the start before we went live, work on the Ormskirk Mess site is actually starting today. The facilities are going to be fully upgraded there, so it's going to be fully decorated. The floor's going to be done. We're looking at having some bladeless fans that are going to be wall mounted, so that if the area is getting very warm, because I'm aware that there aren't outside windows in the mess at Ormskirk. We're also looking at making sure that there's a new TV that is Wi-Fi enabled that you can get access onto. There are a number of chairs that will allow rest within that area, and the plan is that we're looking at some movable screens so that people could have some privacy when they're sleeping. We've also upgraded one of the rooms that is used by the medical registrars, and we're certainly looking at other sites across the across both sites, rooms that are used for rest purposes, is to ensure that they are fully upgraded. It's interesting that you were saying, Robin, that you cover it at the induction. So do I. Part of it is as a result of certainly the BMA's campaign, but also the Association of Anaesthetists has been pushing very hard about the potential effects of fatigue and long shifts on patient safety, really. I grew up in the era, and I point out to people so I've been a consultant coming up for just short of 20 years, but I've been qualified 30 years this year. And when I was in training, I never had a contract that was less than 64 hours a week. So I worked quite a long number of hours, and I have to say the shifts that I used to work in those days, our normal on call would be starting at 9 o'clock or 8 o'clock one day and finishing at 5 p.m. the following day. So not doing a sort of like, if you like, doing a day, a night and a day. And I certainly had a car crash going home after an evening shift, having done a sort of like 30 odd hour shift. So I think it really does bring it home, the importance of sleep and the importance of rest. It's actually taken me a long time to learn the lesson, to be honest. And at one time I would have started, particularly when we had COVID and we had lots of patients on ITU, I would have started a ward round and finished a ward round, no matter how long the ward round took. I'm now getting to the stage, if we're 3 or 4 hours in, which sometimes we are with complex patients in critical care, I have now more frequently said, right, we're going to break for half an hour, go for lunch, have rest, and then reconvene. And I think it's the awareness that it has implications on your decision making and implications on the safety of patient care. And I think really it is very much a culture that we need to change in medicine, but hopefully presentations like this, presentations at induction, and in fact it is included in the handbook, the importance of rest, hopefully helps to change the culture. I think we'd also just like to say we do positively encourage our doctors in training to exception report if needed, because unless we know what the situation is on the ground, we can't change it as senior clinicians and as senior managers. And, you know, there is always a disconnect of knowing exactly what's going on, and unless people feed back to us the challenges that they are having in obtaining appropriate rest, then we can't do things to help it. But the organisation is very much receptive to listening to the challenges that people have and look at ways in which we could address it. Robin, do you think it's what do you think individuals can do that may make a difference?
I think I think there's a number of things. I think for themselves, I think there's clearly a lot of preparation and understanding of their own things. But I think most important of all, I think, is let people know if work is making you tired, if your working pattern is you're overly fatigued. Please let you know. Yes, use the exception reporting system if you're a trainee. That is the formal system, but talk to somebody, raise the issue with your manager, talk to colleagues and feel comfortable, feel confident in reporting it because you all think the same. Share that information. I think that's really is the most vital thing. I would like to just go back to what Anne said about medicine 30 years ago. It just made me think, as the only time in my life, thankfully, that I've been an overnight stay in hospital was round about 30 years ago when I was in my early 20s, and it was a Sunday night, and I had to have a blood taken. A junior doctor who could barely keep her eyes open tried to take blood from my left arm and missed the vein about 4 or 5 times before she extracted some blood. She then came back 5 minutes later and told me she dropped the sample and would now have to take some blood from my right arm, and we went through the same process again. And it really, as a patient, you do not want to be treated by somebody with that level of fatigue. It is clearly wrong, and it's very good to hear a consultant of my age actually not hark back to some glory days of doing 1 in 2s and 60-odd hour weeks, to actually recognise that those times were not some glory days. They were not. It was wrong then, and it would be wrong now to work those sort of hours. And I think it's really important. So hear it from a doctor and just share that briefly as my experience as a patient in virtually the same era. You weren't a trainee at Rotherham District General in 1992 or 19.
I was just about to say that. I hope it wasn't me that did it. No, unfortunately, I was a Liverpool graduate and I stayed in and around Liverpool, so it wasn't me.
It wasn't you.
Okay. I don't think anybody else has got any specific questions that they've asked me to ask you. I have to say I am a member of the BMA, and I find the BJA is useful. In fact, interestingly enough, these days I tend to follow it on Twitter rather than actually, and I find that sometimes a lot of my CPD ends up being done via Twitter on links to articles that you go, oh, that's quite interesting, I'll read that. So I would say that there are many ways in able to access a lot of the BJA and the BMA learning resources, and they're a hugely valuable resource. So I would recommend to people, if you're not a member, please consider it very much. It is a very useful membership to have. I suppose it just remains for me to say thank you very much to Robin. I can apologise for the IT issues that we had earlier on, but I hope that everybody has found the meeting as interesting as I have. So thank you very much and goodbye.
Thank you, Anne. Okay, bye now.